Welcome to The Explainer. Today we are diving deep into a cornerstone of modern obstetrics, preventing Group B strep disease in newborns. Now, on the surface, this should be a straightforward success story. But as we're about to see, it's actually a clinical paradox, one where our very best efforts are uncovering some really unexpected and complex challenges.
So let's just jump right into the heart of the matter, the central question that's got clinicians scratching their heads. We have decades of antibiotic prevention under our belts, so why on earth are we seeing more cases of neonatal GBS disease, not fewer? It's a real puzzle, and it's forcing us to re-examine everything we thought we knew about this bacteria and how we fight it.
And this chart right here, it lays that paradox out in black and white. Since we started widespread intrapartum antibiotic prophylaxis, that's IAP, back in the late 90s, the rate of GBS infection in newborns has actually ticked up. And what's just as concerning is that the mortality rate, well, it hasn't budged. We're intervening more than ever, but we're just not seeing the results we'd expect. Look, this isn't just some statistical blip. It's a huge signal. What this trend is telling us is that our current antibiotic playbook, as essential as it is, might be reaching its limit. It really highlights the urgent need to think outside the box and push for a more permanent solution, something like a maternal GBS vaccine.
Okay, so to really unpack this challenge, we have to start at the beginning. And it all begins with how we figure out which pregnancies are at the highest risk in the first place.
The screening pathway really gets kicked off by two main things. First, you've got the immediate risks, like a threat of preterm birth. But then you've got the historical clues. Did the mother carry GBS in a past pregnancy? Did a previous baby have a really bad, unexplained infection right after birth? These flags from a patient's history are what trigger that universal screening later on. And that focus on patient history isn't just a hunch. It's backed by some pretty stark data. We know for a fact that if a woman carried GBS in one pregnancy, she is 3.6 times more likely to carry it again in her next one. That one number completely changes the risk calculation and tells us exactly why we need to be so vigilant in subsequent pregnancies.
So once we've identified a patient as high risk, what's next? Well, that brings us to the intervention itself. When exactly is the decision made to give antibiotics during labor?
The decision to use IAP really falls into two buckets. On one side, you have the definitive, absolute must-do indications. A classic example? A patient whose previous child had invasive GBS disease. For her, IAP is automatic, no questions asked. Another big one is finding GBS in her urine during this pregnancy. Then you have the gray area, which needs more clinical judgment. Think about a GBS carrier with no other risk factors, or someone who spikes a fever during labor. These are the cases where you have to carefully weigh the pros and cons.
Now that we know when to act, let's talk about the how. What specific tools are we using, and why is picking the right antibiotic so crucial for both the mother and the baby?
You know, for standard GBS prophylaxis, the choice is actually refreshingly simple. Penicillin is the undisputed champion, the first-line choice. It's targeted, it's effective. Now, if your patient has a penicillin allergy, the go-to alternative is clindamycin. But ideally, you'd want to confirm that the GBS strain she's carrying is actually sensitive to.
But of course, pregnancy can get complicated. If there's a suspected infection inside the uterus, we're talking chorioamnionitis, especially with signs of sepsis, the strategy shifts completely. You bring out the big guns, a powerful, broad-spectrum antibiotic combination. And for something like a UTI, the treatment gets tailored to how bad it is, from a simple oral pill for cystitis to IV drugs if the infection has gone systemic.
And that mention of nitrofurantoin for UTIs comes with a huge flashing red light. You must avoid it in the last month of pregnancy. Why? Because of the potential risks to the newborn, including nerve damage and a specific type of anemia. It's such a crucial reminder that every treatment for the mother has to be weighed against its potential impact on the baby. Okay, we've covered a ton of ground here. The paradox, the screening process, the specific drugs. Let's hit pause for a second and really lock in a few of these critical takeaways with a quick knowledge check.
Okay, think back to that decision-making table. We know that having a previous baby with GBS is a big one. But what's another one of those absolute non-negotiable reasons to start IAP, even if a late pregnancy swab comes back negative?
The answer is B.
finding GBS in the mother's urine at any point during her pregnancy. This is what's known as GBS bacteriuria, and it's a major red flag. It's considered a sign of a very heavy or severe colonization. The bacterial load is just so high that the risk to the baby skyrockets, making antibiotic prophylaxis absolutely mandatory.
All right, next up, what about our primary weapon in this fight? For a patient with no known allergies, what is our go-to standard of care antibiotic for GBS prophylaxis?
That's K, benzoyl penicillin, and is chosen for a very specific reason, not just because it works. It has a narrow spectrum of activity. This gets to a key principle of antibiotic stewardship. Why use a sledgehammer when a scalpel will do the job? It targets GBS effectively while causing minimal disruption to the rest of the mother's beneficial microbiome.
And for our last question, let's bring it all the way back to the paradox that started this whole discussion. Since IAP became the standard of care, what has actually happened to the overall number of newborn GBS cases?
The answer, crazy as it sounds, is C. It has increased. This is the core finding that is driving so much research right now. While IAP is great at preventing early onset disease, that's the infection in the first few days of life, we've seen a rise in late onset disease. The reasons are still being figured out, but it tells us in no uncertain terms that our current strategy is not the complete solution.
So after all this, where does that leave us? Well, the data is pretty clear. If we really want to get a handle on this problem, we have to start looking beyond the antibiotic itself and think about the much bigger biological picture.
And here's the other really critical piece of the puzzle. Our interventions have consequences. Giving a mother antibiotics during labor, while it can be life-saving, also dramatically alters her baby's brand new gut microbiome. And there's a growing body of research linking that disruption to potential long-term health problems for the child, like a higher risk for asthma and for adiposity, or increased body fat.
There's an old saying in medicine that just hits the nail on the head here. It's a reminder to use our clinical judgment to treat the whole person. But it has a flip side, right? Because sometimes, like with GBS found in the urine, that single lab result is the patient's biggest problem, and you absolutely have to act on it. And all of this funnels down to one final huge question. When you look at the rising incidence rates, the flatline mortality, and these growing concerns about the microbiome, is our antibiotic strategy the endgame, or is it just a temporary fix, a necessary stopgap, a prelude to the real solution we're all hoping for, a safe, effective maternal vaccine? That really is the challenge and the hope for the future.